2024. And today we have Professor Gladstone Airewele, a good friend and a brother, who will talk to us today about sickle cell traits, the myth versus the reality. He's going to share his experience with us. He works at Texas Children's Hospital. Even though this presentation is being made from London, I had to drag him out of his holiday to make this presentation. So I'm very glad that he's here with us. Dr. Temie will be our moderator for today. But before we start, I would just like to hand over to the president of our association, Dr. Mobolaji Lawal, to please give us the opening remarks. Thank you. Over to you, sir.
Okay, thank you very much, Sinde. I'm glad to welcome everyone to this meeting today. The speakers, the moderator, and every participant who has joined so far, including those who are yet to join. Today we have a very interesting topic, and when I look at the topic, sickle cell trait, myth and reality, myth versus reality. I know that we are familiar with the speaker. He's an eminent pediatrician, an expert in pediatric hematology and oncology, Professor Gladstone Airewele, Texas Children's Hospital. He's been on this platform before, about 2 years ago. At that time, he was talking about the transplant, the conundrum introduced by transplant for sickle cell patients. And we had a very exciting meeting that day. So having him come back today and with this very interesting topic, I can't help but think that something more interesting is going to happen today. We are talking of a condition that is so common. The last time I knew it was 1 in 4. I hope the statistics hasn't changed in Nigeria. And to now think that there may be some myths and some realities there, I said to myself, maybe Professor Airewele is about to unravel something interesting for us today. So I'm very anxious to listen to what's the lecture today. And we have a very, very eminent moderator in the person of Professor Temie. He's also a well-known professor of hematology and pediatric hematology and oncology at Lagos University Teaching Hospital. So all in all, we have a very, very good team to lead us through today's meeting. And I won't take too much of your time other than to welcome you and to say I'm very, very pleased to do so. And I hope that we have a very, very robust conversation and lecture today. So over to you, I think to Dr. Temie now to carry on with the proceedings of the day. Thank you very much.
I'm not sure Dr. Temie is here now. I haven't seen him online.
Okay, so maybe you will take over.
He had told me earlier that he was involved with medical students' exams, but in his absence, I will ask Dr. Akishete to moderate spend. Shaya, are you online?
Good afternoon, everyone.
Yes, it is.
I'm actually a visitor on the call, sir.
Can you moderate?
Okay, sir. So, good afternoon, everyone. We'll be listening to Professor Gladstone Airewele. He's going to take us through the talk on sickle cell trait, myth versus reality. So I'll just enjoin us to down our questions and comments, and I promise that it's going to be pretty interesting. So thank you very much as you listen attentively.
So over to your Gladstone.
Oh, thank you very much, Dr. Lawal, Sende, and Sheye. I'm so glad to be here to speak with you about sickle cell trait. I realize that sickle cell trait is so common in Nigeria, but what I will hope to do over the next 45 minutes to 50 minutes or so is to give you a flavor of the controversy that has been part of sickle cell trait in North America. Specifically for this presentation, I do not have any actual or potential conflict of interest. And as I mentioned, hopefully in the next 45 minutes, I will share with you about the diagnosis of sickle cell trait. You may be wondering why I have to tell experts in pediatricians in Nigeria about how to diagnose sickle cell trait. At the end of the hour, at the end of the 45 minutes, perhaps you will see my own point of view to see why the diagnosis sometimes is not as straightforward as it seems. I will also, as part of the discussion, we will talk about the sickle cell trait mimics, because from time to time we have patients who have sickle cell trait and then who have symptoms that look or sound like symptoms of sickle cell disease. Although sickle cell disease is well known to be an autosomal recessive condition, there are some complications that have been associated with sickle cell. And then if you look in the literature, there are several claims. So this talk will also help you classify the associations into what's definite, probable, and possible, or completely unrelated. You may also know that the American Society of Hematology significantly disagrees with the NCAA, which currently requires testing for sickle cell trait for young people to participate in competitive sports. For those who do not know, the NCAA is the organization that regulates the athletic participation of university students. It covers over about 11 to 1,200 colleges and more than 500,000 athletes. For those who are following the current basketball so-called March Madness, it's a cultural end of winter, beginning of spring ritual in the US. And lastly, every pediatrician should be able to, at least every pediatrician in Nigeria should be able to sustain at least 2 minutes of discussion about sickle cell trait and disease in a cocktail party, because this is something that is so common. First of all, I chose the topic, and after I chose it, I decided to ask myself, I said, exactly what is a myth? If I asked you, I'll say that, is it true that Zeus, the god of gods in Mount Olympus, the Greek Zeus, is the father of Hercules? Or is it true that Shango was as I understand it, Shango was once the Alaafin of Oyo, and then Shango is still with us today, dispensing justice to everyone. So myths, according to this philosopher who was an advisor to a one-time emperor of Rome, myths are things that never happened, but always are happening. And exactly what about reality? If you think about it, reality is, there was once in the world when same-gender attraction was a mental illness. For 50 years now, it is no longer the diagnostic and statistical manual of disease, no longer classifies same-gender attraction as a mental illness. It's just normal now. So in a sense, the nature of myth and reality Although I'm going to talk to you about sickle cell trait and what's myth, what is reality about it, I beg you to take everything I say today with a pinch of salt, considering the fact that reality is nothing but the collective hunch. Excuse me. I saw this paper. This was published in the American Journal, the Journal of Hematology, sometime last year, where it asks, it says, sickle cell trait, is it always benign? This case series was that of 3 or 4 young adults who had avascular, with sickle cell trait, who had avascular necrosis of the femoral head and who required hip replacement surgery. When the authors asked, is sickle cell trait always benign? When I read it, the way I responded to it was, well, if I drive the speed limit in Ikorodu Road with a new car that is well maintained, am I guaranteed to not have an accident? Is it always so that I would never have an accident? And I'll leave you to answer that. So is the sickle cell trait always benign? What about these papers? I took 2 publications from a couple of years ago where one of the doctors specifically argues, really strongly that sickle cell trait is a risk factor for early stroke using large databases, while another doctor in the same publication argues equally strongly that, of course, it is not a risk factor for stroke. And anytime you see us argue back and forth about medical matters or matters such as this, I just remember the words of Arnold Glasser, where he says that, well, we only argue when there are no facts. The fewer the facts, the stronger the opinion. We don't argue about things that have a lot of facts. Sickle cell trait, we agree, will cause difficulty concentrating urine because of the effect of potential sickling in the highly hyperosmolar acidic renal medulla. We agree that sickle cell trait protects against malaria. There is some data, more recent, that individuals with sickle cell trait are more prone to chronic kidney disease. Chronic kidney disease defined by creatinine level, and that people with sickle cell trait are also more likely to have albuminuria. Taking that aside, over the last 40 years or so, with the advent of universal newborn screening in many parts of the world, a lot of data has come to inform us about sickle cell trait. Because while children are being diagnosed with sickle cell disease, the ones with trait are being identified, and significant databases have teaching us more and more about the associations, the disease associations with sickle cell trait. The bottom line is that the person with sickle cell trait, as you know, can have a child with sickle cell trait or sickle cell disease depending on the hemoglobin status of their partner. A study out of Michigan, I think this was about 5 years ago, followed about 20,000 children with sickle cell trait, compared them to another 80,000 or so children without sickle cell trait, and confirmed that the children with sickle cell trait were not more likely to use medical services, meaning they were not sicker. We also know that individuals with sickle cell trait have a normal quality of life, and they have a normal life expectancy compared to those who do not have sickle cell trait. But that hasn't stopped a lot of publications. All the conditions that are listed on this slide are conditions that have been published at least one time to be associated with sickle cell trait. The ones in red are the ones that I'm convinced have a probable or definite association. Certainly the issue of difficulty concentrating urine, the issue of blood in the urine, hematuria, likely due to papillary necrosis, chronic kidney disease, proteinuria, and more recently, the risk of exertional rhabdomyolysis, renal medullary cancer, and traumatic hyphema with difficulty with secondary hemorrhage are conditions that have been definitely or probably associated with sickle cell trait. The ones on the green side, it's very unclear, and the data has been all over the place. As an example, acute intermittent porphyria in a patient with sickle cell trait who died was found to sickle cell trait was found in a patient with acute intermittent porphyria who had fatal small bowel infarction and died. Does that then mean that sickle cell trait is associated with AIP and bowel infarction? I'll say no, because the data doesn't indicate that. But then all of those conditions have been published at least once in association with sickle cell trait. Going all the way back, you should be familiar. I mean, this is a chit-chat moment. You should be familiar with the story of Walter Clement Noel, who in a student, a graduate from a college in Grenada in the Caribbean, who traveled to Chicago to study dentistry. While he was there, he was admitted to the Presbyterian Hospital in Chicago. The hospital is now part of the Rush University Medical School, and the house officer who took care of him looked under a microscope, a technology that had just been developed at the time, and noticed the sickle cells in this patient who happened to be the first recorded case of sickle cell anemia, at least in Western medical literature. Walter Clement Noel graduated from dental school in 3 years with his mates, then moved back to Grenada. And the rest of the story is that sometime in 1916, while at the age of 32 years, Dr. Noel got on his horse, traveled a far distance from home on the island of Grenada to attend a horse race. And then when he came back, he had overexerted himself, and then he died from what the death certificate called asthenia from pneumonia. I put this here as a way of saying, of linking this to the issues of exertion that have been associated with sickle cell trait, which we are going to talk about some more. From that early beginning with Walter Clement Noel, we now know that sickle cell trait is the heterozygote form of sickle cell disease. And both of these, the trait and the disease, are inherited. We now know that is common. 20 to 30, the publications out of Nigeria indicate that 20 to 30% of Nigerians carry the sickle cell trait, which leaves us to, if you just rough back of the envelope numbers, will indicate 40 to 70 million Nigerians with sickle cell trait. Part of it, more than 300 million people who have the sickle cell trait worldwide. Based on data from the US, 1 in 140 Latinos have the sickle trait, 1 in 14 Blacks, and 1 in about 300 white Americans carry the sickle cell trait. 1 in 350 to 400 white Americans have the sickle cell trait. As I mentioned, the sickle cell trait is the heterozygote form where a person inherits 1 normal beta globin gene and 1 sickle globin gene. Based on the chemistry of the mutated sickle globin genes and the normal globin genes, there is a reduced affinity of mutant globin genes for normal alpha chains. As you remember, a hemoglobin molecule consists of 2 pairs of genes, 2 alpha and 2 beta. But in the presence in a person who makes mutant beta globin genes, these globin genes have a reduced affinity so that most of the alpha chains combine with the normal beta genes compared to the mutated sickle globins. For this reason, in the diagnosis of sickle cell trait, if you do a quantitative electrophoresis or HPLC, the hemoglobin A, for the reason that I mentioned earlier, normal beta globin chains have a higher affinity for alpha chains compared to sickle mutant chains. For that reason, the hemoglobin A must be more than the hemoglobin S. If you look for indicators of hemolysis, like reticulocytes, LDH, haptoglobin, there should be no anemia or hemolysis. And if you look under a microscope, the red cells should have normal red cell morphology. Based on these criteria for diagnosis, you will see that the use of a hemoglobin, of the so-called hemoglobin solubility, sickle solubility test, or the sickle dex, or some have encountered cases where people look under a microscope and use plasticine and sodium metabisulfite to see if they're sickle cells. These are not considered adequate for diagnosis of sickle cell trait. You should also bear in mind that if you look at quantitative electrophoresis or HPLC from a person with sickle cell trait, there's usually a higher than average amount of hemoglobin A2, so that the presence of hemoglobin S raises the detectable amount of hemoglobin A2. As I mentioned earlier, mutated sickle mutant beta globin chains have a reduced affinity, so that for most people, it will be a 60% hemoglobin A to 40% hemoglobin S to diagnose it. This discrepancy between hemoglobin A and S is further accentuated in people who have alpha thalassemia. The estimate, I've seen some estimates from Nigeria, and it's similar to the estimates of Blacks in the United States, is that about 25 to 30% of Nigerians are missing at least one alpha gene. They have 3 instead of 4. In this situation, instead of 40 to 45% sickle hemoglobin, the amount of sickle hemoglobin is further reduced. And amongst the 2 to 3% of Nigerians who have the alpha thalassemia trait, the amount of sickle hemoglobin is further reduced. So that looking at a hemoglobin profile, you may be able to also surmise the presence of co-inherited alpha thalassemia. What about sickle cell trait mimics? In the early 2000s, a child in Boston who had been born and diagnosed with sickle cell trait was on his way to Puerto Rico on a flight, developed significant spleen sequestration. And when they took her to hospital, although she'd been diagnosed with sickle cell trait, hemoglobin, what looked like hemoglobin AS, she had evidence of sickle cell disease. So although it looked like sickle trait, when the doctors did gene sequencing, they were able to find that this child on the same chromosome, the one that she inherited from her father, the one with the sickle cell trait mutation, there was a second mutation, a mutation that has been associated with hemoglobin Rockford or hemoglobin Love Parks, where that further reduces oxygen affinity for hemoglobin, such that this child has a hemoglobin, a globin gene that has two mutations, one for sickle cell and one for hemoglobin Love Parks. The doctors in Boston named this new hemoglobin Jamaica Plain after the neighborhood in Boston, similar to how if this kid lived in Ajegunle, we will say this is hemoglobin Ajegunle. They call this hemoglobin Jamaica Plain after the place where this child grew up. This is an example of autosomal dominant sickle cell disease in a person who appears to have sickle cell trait, because she had a spontaneous mutation in the paternal gene that added a second mutation. So she has what looks like sickle cell trait, but has sickle cell disease because this is autosomal dominant. And that is not hemoglobin sickle, that is hemoglobin Jamaica Plain. Hemoglobin Jamaica Plain is not the only example of autosomal dominant sickle cell disease that has been found. Hemoglobin Antilles predates hemoglobin Jamaica Plains. This is another example of a hemoglobin where on the same gene there is a mutation causing sickle cell disease, the valine for glutamic acid mutation, in addition to a second mutation in the same gene. Because of this second mutation, these so-called autosomal dominant or super sickling sickle cell disease can produce symptoms in heterozygous state, either because the new mutation significantly reduces oxygen affinity or significantly reduces the stability of the molecule. In addition to hemoglobin Jamaica Plain and hemoglobin Antilles, hemoglobin S. Oman and hemoglobin Sao Paulo are other examples of autosomal dominant sickle cell disease, where a person who inherits only one sickle cell gene develops disease. So if you're encountering a person who appears to have sickle cell trait and who has hemolysis, has a pain crisis, this is what you think of. Another example, this is another case report. A couple of cases have been described of this condition, where a child who was born in Quebec, in Canada, diagnosed with sickle cell trait, developed evidence of hemolysis and pain events. On mass spectrometry and gene sequencing, the doctors in Oakland diagnosed and found that this was not actually what looked like hemoglobin A, was not actually hemoglobin A. It was an electrophoretically silent variant that moved along with hemoglobin A, but wasn't hemoglobin A, had a mutation, and so they named it hemoglobin Quebec Chori. Quebec for the area where the child was born, and Chori for the place where the mutation was, where the investigators, the lab scientists did it. The Chori stands for the Children's Hospital of Oakland Research Institute. So another example of a child who appeared to have sickle cell trait, but who didn't. What about these case reports? These were people in Africa who had sickle cell trait and had symptoms. In both of the cases, they found out that they also co-inherited mutations for pyruvate kinase deficiency. So sickle cell trait plus pyruvate kinase deficiency can cause sufficient reduction in oxygen affinity of hemoglobin, because as you know, pyruvate kinase deficiency causes an increase in the erythrocyte 2,3 DPG levels, such that even in the presence of sickle cell trait, one mutation for sickle cell in a person who has pyruvate kinase deficiency can develop pain crisis, splenomegaly, leg ulcers, kidney disease. So another example, we've talked about the autosomal dominant forms, we talked about hemoglobin chori, and now another example of a person who seems to have sickle cell trait, who has sickle cell trait, but is symptomatic because of other conditions. This is an interesting report where a person who inherited only one hemoglobin, who inherited sickle cell trait, was found to have sickle cell disease on account of uniparental disomy. Uniparental disomy is a situation where a person inherits the two copies of the same gene from the same parent, just a recombination event. So in this situation, this child's mother did not have any form of sickle cell disease, had completely normal beta globin chain, but when the child was checked, she seemed to have sickle cell anemia, because the paternal sickle cell, because the beta globin genes had been inherited from the same parent. It caused confusion because it seems like this kind of recombination event was a post-zygotic event, meaning it happened after the cells had started to develop, such that the child was a mosaic. So one parent with sickle cell trait, only one parent with the sickle cell mutation results in a child with sickle cell disease on account of uniparental disomy. So going forward, the kinds of questions that you get from patients, it says, oh, I have sickle cell trait. Can I get anesthesia without any problems? Yes, if your anesthesia is done with competent anesthesiologists, where there's no, where they don't allow you to become hypoxic, yes. Can you use hormonal birth control? I say yes. Can you exercise to stay fit? This became an issue because of the reports of sudden death in people with sickle cell trait. I will say yes, for reasons I'm going to explain later. Can a person with sickle cell trait donate stem cells or other organs? I say yes. In fact, 2 to 1, the people who donate stem cells for their siblings with sickle cell disease, there are 2 times as many siblings with sickle cell trait as the ones with sickle cell, as the ones with normal hemoglobin. So yes, and the results are the same. Can a person with sickle cell trait donate blood? I'll say that's a qualified yes. In the US, or at least in our hospital, where all blood is pre-storage leukodepleted, it's been found that people with sickle cell trait, when they donate blood, they are more likely, when the blood bank tries to filter out the white cells, a person with sickle cell trait is more likely to be deferred, meaning their blood refused, because the filter that is used to remove the white cells is more likely to fail. It fails in some, but not in others, so that on average, only about 50% of 30 to 50% of people with sickle cell trait are able to donate blood. Not because there's anything, not because their blood doesn't carry oxygen, but just because the filters, it's a technology problem, the filters that is used to remove the white cells are prone to fail. But once the blood comes in, the blood is used for all categories of patients, except at least in Houston or in the US, for people who have sickle cell disease, because if we do, we cannot estimate how much sickle hemoglobin levels if it's been monitored, and it's also not used in children, in babies who have in very low birth weight infants. You may not be familiar with this guy. This is Ryan Clark. He was a Pro Bowl, very highly talented safety for the Pittsburgh Steelers in the American Football League. So going forward, I'll say football for American football, soccer for the real football. So Ryan Clark, sometime in 2007, has sickle cell trait. He's a star player for the Pittsburgh Steelers while he was playing in Denver. Denver is about 5,700 or 5,800 feet above sea level at altitude. He was playing a game and he developed a spleen infection. He missed the rest of his season. And they eventually had to remove his spleen, and according to newspaper reports, remove his spleen, removed his gallbladder. I don't know why the professional NFL doctors did all that, because in general, multiple case reports of people who have sickle cell trait, who, if they go to place with elevation, can have acute spleen infection. Even people with sickle trait who fly in small Cessna aircraft that are unpressurized also risk spleen infection. I cannot think of anywhere in Nigeria that is high enough that somebody who flies to will suddenly have a spleen infection. But for all the folks on the line, if you fly to Kampala, elevation 4,000, or to Johannesburg, maybe about 6,000, if you have sickle trait, or if your patients have sickle trait, advise them to get to where they're going, relax for a few days to become adjusted to the area. Because if you look at people with sickle trait who live in these high altitude places, they do not develop acute spleen infection. It tends to be people with sickle trait who arrive in Nairobi, in Denver, in Joburg, or Salt Lake City, immediately are dehydrated and they start to exercise, who develop these. And although the issue of sickle trait causing spleen infection has been known, Ryan Clark developed spleen infection so bad that even in 2012, during a playoff game, a really important game for his team, his coaches refused to play him in Denver. And this was a game against the Denver Broncos. They ended up losing. And for those who look at American football quite closely, you will see that it will seem like they lost specifically because their best defender was not available. I wonder why they didn't play him, because after all, they'd already removed his spleen. So because of the record of spleen infections in people, there's a lot of speculation about why is it that the majority of the people who have spleen infections with sickle trait, they tend to be more white than black. In fact, a recent analysis that combined a lot of all the cases, like a meta-analysis or a systemic review, identified close to 100 spleen infects in the literature, and only about 20-25% of them were black people. And then some people say, well, is it possible that whites are more susceptible? I said, do not write papers like this. I don't think whites are more susceptible. In my view, I think the people who are more susceptible to spleen infects are people who are well-fed, who've paid their mortgage, have plenty of money, and then they go climb mountains, right? If you don't go climb mountains, you don't have it. So I don't think white people are more susceptible. You could have just, instead of saying that whites more susceptible, just change the surrogate, say are rich people more susceptible. And I think that will be an equally true statement. There's a story that is told of a father whose son went to Santa Fe, New Mexico, a sickle cell trait. The boy developed a spleen infarct, and then they put a phone call to his dad to come see him because he was in hospital being hydrated and stuff. And the dad rushed to Santa Fe, New Mexico as soon as he could. And once he got there, he also developed a spleen infarct. So the first order of business, if you ever have to treat somebody with a spleen infarct at altitude, is to move the patient to lower altitude. So that way, when the relatives who also happen to have sickle trait come to visit them, you don't have 2 patients on your hands instead of multiple patients instead of just one. Multiple publications also indicate that patients with sickle trait individuals with sickle trait also have a modest increase in their risk for pulmonary embolism and venous vein thrombosis. It is moderate, and the extent of, so in a sense, it's a mild thrombophilia, hypercoagulable state, but it's mild, moderate increased risk, not to the point of requiring adjustments in the duration of anticoagulation or the type of anticoagulation that's used. I already mentioned the issue of hypostenuria, that persons with sickle cell trait are less likely able to concentrate urine to the same level as the osmolarity of plasma, similar to those with SS disease. This is Kyle Blakeman, a 15-year-old who died in 2007 in Denver. He had sickle cell trait and renal medullary carcinoma. So renal medullary carcinoma is an aggressive cancer that has been defined or described only described in people with sickle cell trait or disease, highly aggressive. What this means, if you see a person with hematuria due to sickle trait, you could simply assume that it's papillary necrosis, but bear in mind that there are multiple case reports of individuals, young people with sickle cell trait, who develop renal medullary carcinoma, a highly aggressive cancer that can be better treated if caught early. The incidence of invasive pneumococcal disease is higher in Black individuals who have sickle trait compared to whites, at least 77% higher, and at least 42% higher when you see a person with sickle trait compared to a Black individual who does not have sickle trait. But see how the incidence has generally gone down, and I think that this is the Prevnar effect. So after the conjugate pneumococcal vaccine came, the difference has become less noticeable. So this is something that's also reported. Sometime in the late 60s, the US military started to report cases of sudden death amongst their soldiers. The first ones were reported out of El Paso in Texas, in Fort Bliss in the Army barracks over there, where individuals, this case report describes 4 of them. Fort Bliss is about 4,000 feet above sea level, where they described 4 individuals who came in. They were military recruits being trained to join the army, either because of abnormal heat exposure, dehydration, arrhythmias, who suddenly died. On account of this, Dr. Kerr published this in the late 80s, where they found that recruits, after examining the records of about 2 million recruits, 250,000 of them who were African Americans, found that the risk of sudden unexplained death was at least 15 times higher in Black recruits with sickle trait compared to those who do not have sickle trait. On account of this, the U.S. Army adjusted its training to take the temperature outside into account and to basically reduce the extent of the training. So 15 to 20 times higher risk of death amongst individuals with sickle trait compared to those who do not, in this New England Journal paper. This information has been fairly controversial because the same investigators then described how after they reduced the intensity of training and accounted for temperature, environmental temperature, that those deaths significantly reduced. In 2012, Dr. Harman in the British Journal of Sports Medicine published a paper that showed that amongst Division I American football players, the risk of death amongst those who had sickle cell trait was at least almost 40 times higher than the risk in those who do not have sickle cell disease. This is a figure I took from that publication. Notice how in athlete deaths in young people is the 4 H's. There's the issue of trauma. Almost 3/4 of all these young people who died from accidents, suicide, basically trauma. And compared to sickle disease, there's the issue of the heart. A lot of them have cardiomyopathies, and then they have sudden death, even more important than the 2% or so who died to conditions that were attributed to sickle cell trait. The issue of sickle trait in the US Army was significantly clarified recently. This study looked at 50,000, this is a more recent study, looked at 50,000 Black soldiers in the Army branch of the US military, and looked to see if there's a difference in mortality between those who had sickle cell trait versus those who did not. Bear in mind that this study is different from the one I mentioned before, because the US Army now has accounts for acclimatization when they go to altitude, accounts for ambient temperature. The training has been moderated. And in this study, Dr. Nelson and his and the colleagues did not find a higher risk of death in Black US Army soldiers. However, they found that the risk of rhabdomyolysis, muscle injury with muscle breakdown, with hemolysis, with heme in blood, was higher amongst soldiers who had the sickle cell trait compared to those who did not. Unlike the previous study that was unadjusted, this study accounted for some co-founders. So some of the most important co-founders that were found in relation to rhabdomyolysis was that the soldiers who smoked, the soldiers who were overweight, and those who were on cholesterol medicines or antipsychotics were also more likely to have rhabdomyolysis. But even after regressing or accounting for all those other factors, sickle cell trait was a risk factor for rhabdomyolysis. Most of the deaths due to sickle cell trait have been linked to heat injury or heat stroke. So this study just simply asks, amongst the same 50,000 Black soldiers, is that does sickle cell trait increase the risk of collapse from heat injury? These investigators did not find any association between sickle cell trait and heat injury or heat stroke amongst US Army soldiers. The issues that, the factors that most predicted heat injury and heat stroke amongst the US Army soldiers were the use of antipsychotics. A person who had a previous heat injury was more likely to have heat stroke, and obesity. These were the factors, but sickle cell trait was not a risk factor for heat injury or stroke. Since we know that exertional rhabdomyolysis, meaning muscle injury, could since sickle cell trait could cause muscle injury, do the sickle cell patients who develop muscle injury, do they get sicker than the ones who don't have sickle cell trait? So this study looked at about 400 patients, 400 individuals who had rhabdomyolysis in the US Air Force over a 10-year period. And amongst all the ones who had rhabdomyolysis, there were some with sickle cell trait and some who didn't have sickle cell trait, but having sickle cell trait did not make the person more likely to be hospitalized for rhabdomyolysis or to go into the ICU or to need hemodialysis. So that sickle cell was not a factor determining the severity of rhabdomyolysis. So because of the risk of the reported risk of death, I'll say over the last 50 years, at least 30 college players and several others in high school have died, and they've had their deaths attributed to sickle cell trait. This picture is just a few of the young people who have died due to sickle cell trait. I'll just highlight two of them. Day Lloyd, this young man was 19. He died in Houston, Rice University, a fantastic athlete. They were training on the field. He suddenly collapsed. He was taken to the medical center, found to have a significant rhabdomyolysis, died from cardiac arrhythmias. His family sued. His family suit is that, well, he has sickle cell trait. How come you did not help prevent it? Another one, Devon Darling. This young man, high school in Houston, one of identical twins. He played in defense, American football defense. His brother, his identical twin, played in offense. This young man died during training in Florida State University. Because he died, the university then practically did not clear his twin brother, his identical twin brother, to continue playing for the university. So Devon Darling, his brother, transferred to Washington State University, where he completed an American football career and ended up being drafted into the professional league, where he played for another 7 years as a wide receiver. So identical twin, one died in Florida State. The university says, oh no, the risk is too much. He goes to a different university and then dies. So this issue has been a vexing issue for college sports. As I mentioned, this young man who died in 2006, 2007, his family sued. And there was a settlement with the NCAA, such that today the policy of the National Collegiate Athletic Association is that if you want to play college sports, whether it's Division 1, 2, or 3, you must either be tested for sickle cell trait or show proof that you've been tested before. Say maybe your newborn screen result, you have to show them. There used to be an opt-out where you say, look, I don't want to be tested. I say that I won't sue you if anything happens to me, but they've removed that option. So today, if you have to play sports in any, whether it's soccer or football or anything, you have to do a genetic test. As soon as the NCAA announced this years ago, a lot of the doctors were up in arms, not just the American Society of Hematology, the American Pediatric Association, the American Genetics Association. Everybody disagreed with the NCAA, at least almost everyone. The NCAA says to have everyone be tested, and then so that when you ask, they say, what exactly would you do if you find a person be tested? They also have an education program. So this slide is what I copied, pasted from the NCAA's website, where it advises young people who have sickle trait about what to do. I'll just highlight some of it. It says, oh, know your sickle trait status. They've already made that so that everyone should get it. It says, oh, you should avoid pushing with all-out exertion longer than 2 or 3 minutes. I say, okay. It says, oh, maintain proper asthma management. And lastly, the one I really like, this one, it says, oh, you should seek prompt medical care when experiencing unusual physical distress. Does this mean that if I don't have sickle cell trait, if I have unusual physical distress, I should just keep on playing? So quite predictably, the American Society of Hematology, the American Academy of Pediatrics say, no, we do not think that a person's genetic information should be a requirement for participation in sports. And in any case, we ask, according to most professional societies, it says, well, for young people, we need to preserve their right to, we need to preserve decisional autonomy. Should we be testing people for carrier states for something that doesn't have any harmful manifestations in childhood, or for somebody who's not trying to get pregnant or have a baby? Is it possible that testing can have an adverse impact? Is there a right for me not to know what my sickle trait status is? Is it possible that this kind of policy that is huge, the NCAA has prescribed, could lead to labeling, stigma, and discrimination? This is a newspaper report from 2010, around the time that this policy was instituted, that then interviewed 3 football players in University of Oklahoma, and a Division I school with a big football program. It says that Price Macon, one of the defensive players, told the journalist that all my teammates call me Sickle. So meaning that the NCAA thinks it's okay for one of the players to be called Sickle, so that when he's running, the other players, he says, "Oh, Sickle, Sickle, pass me the ball." That is where we are. Remember the gentleman, the Ryan Clark, the safety for the Pittsburgh Steelers, who had his spleen removed? He says that when he became a free agent, the salary they paid him, how lengthy the contract they were going to give him, it became an issue during his off season. So is there risk of discrimination, and will it affect his economics? Or consider this statement that is given to the parents of children who come to consult. This is language from the Texas Department of State Health Services. Remember the kidney cancer that I mentioned earlier. So basically, my doctors across Texas and across the country, you have a baby, you come home with a baby. Imagine that this is your first child. You get home, this baby looks completely perfect. The fingers, 5 toes, everything. Then you get a letter from the state. Then you go see a pediatrician. And then the pediatrician tells you, oh, very rarely you can have a very rare cancer. And then I tell you, I say, verily, verily, I say unto you, if you have to say very rare twice in the same sentence, to me, it is not worth mentioning to the family. The doctors can know it. Because what is the risk of creating, distorting a parent's perception of their child? Is it possible that you use statements like this and all these discussions of rare things to turn a child whose parents already assumed him to be normal into a patient in waiting? Do you create a vulnerable child inadvertently? These are questions that are important. As I tell my colleagues, this is the slide that makes the most sense to me. I mean, I think it makes sense because I work in Texas, but I come to Africa quite a bit to work. This slide from the Lancet in the early 2000s looks at all-cause mortality for under 5s. As you can see, the children with sickle cell trait have the best survival. So that I joke with my colleagues sometimes. I say, look, if I was working in rural Nigeria where there's no doctor for 50 miles, and I'm doing a newborn screening program, if I find sickle trait, I'm going to burst into the delivery room, high five the father and say, congratulations, you are less likely to die. And regarding the issue of persons with sickle with heterozygote conditions, I thought of, well, why don't you think of another heterozygote condition that is maybe doesn't involve as many Black people? Cystic fibrosis. It involves your sinuses, your lungs, your GI, your pancreas. It's autosomal recessive too. And as things to have it, we now have a newborn screening at the same time that the sickle cell is done for cystic fibrosis. So I searched the literature. There's a recent paper that shows that when the doctors looked at all the conditions that are linked with cystic fibrosis and looked for the prevalence or the incidence in heterozygotes, in the carriers, they find that all the 59 conditions that they looked at were more prevalent among carriers. And I'm talking about conditions like pancreatic cancer, adenocarcinoma, infertility, chronic pancreatitis, bronchiectasis, non-TB mycobacterial disease. So that if you see, it seems to me that autosomal recessive conditions, the heterozygotes, we risk making life pathological. We risk pathologizing normal variations in populations. And it's not just cystic fibrosis. If you look at hemophilia, X-linked condition, females are carriers. There's a good number of females who are carriers who have hemophilia themselves. Or if you look at Duchenne muscular dystrophy, the carriers, up to 25% of them may have cardiomyopathy. So it seems to me that most conditions has a continuum of expression between the heterozygotes and the homozygotes, such that when we focus on, with our statistics on specific complications, we risk making normal life pathological. And regarding the issue of kids with who have who die from who die in athletic activity. This is a little snippet of a movie that that is not playing, which I wanted to show you. It is the movie Remember the Titans. This young man here comes to his coach. He says, coach, we need a water break. And his coach, Coach Boone, I don't know, this is a great movie to watch. Coach Boone, played by Denzel Washington, says, a water break? Water is for cowards. Water makes you weak. We are going to go up and down until you are no longer tired or thirsty. I have the impression that this is the reason why people die in athletic activity who have a sickle cell trait, and we need to look at it like that. Why do I say that? In 2011, there were 13 football players in the University of Iowa football team who had to go to hospital after training session because they were all peeing blood. There was blood in their urine. More recently in Houston, 12 or 14 soccer players in the women's team in the University of Houston were admitted to or had to go to hospital. A few of them admitted because they were peeing blood. This is not just a university phenomenon. Just last year, a high school coach in Dallas was sacked because about 15 of the high school players were in hospital, 15 of them, because they were peeing blood. They had rhabdomyolysis, peeing blood, too much exercise. And so as I was preparing this talk, I'm thinking of Barack Obama, who says, oh, if I was a football fan, I will have difficulty getting my child to play football. I agree with him. And it's not just football. Think of it. Even in soccer, when we listen to Nigeria playing Ivory Coast, oh, it's a 4-4-2 formation. Oh, it's an attack and the defense. It's a counter-attack. Oh, it's a midfield battle. Alex Iwobi is dominating the midfield. We have appropriated the language of war into sports such that people then make it a do or die. I don't know if I mentioned to you that of the 50 or 60 athletes who have died playing sports, none of them has ever died during a game. All of them died during conditioning or as part of training when they were doing practice. They all died during practice. And I should have also mentioned that the overwhelming majority of them died playing football, not basketball, not soccer, football. And as I like to mention to my friends, this is an African team. As you know, they've been in the World Cup twice. I searched the web. I have not found a case of a death due to conditioning or practice in soccer from Brazil, from France, from Nigeria, from anywhere. And people tell me, oh, maybe it's because American football is played in the heat. I say, well, if you go to Brazil, you see plenty of heat. If you go to Paris, you see plenty of heat too. So just to come into conclusion, this is another paper, this is another New York Times article from just 2 years ago, where that talks about how the sickle cell trait gives police cover for murder, right? I don't know if those in the audience know, when George Floyd died in Minnesota 3 years ago, everyone saw the police officer's knee on his neck, and we all conclude that that's why he died. But when George Floyd was taken to the hospital for his autopsy, he had sickle cell trait. He had his, when the pathologist cut open his spleen and his muscles, there was widespread sickling in his blood and his tissues. I don't know why it is surprising to find sickling in a dead person, because death is the ultimate hypoxic environment. But this newspaper report indicates that there are close to 50 people who die in police custody, probably been beaten to death, had sickle cell trait put in their death certificate, and it became a factor in either judgment of the police officer who killed them. During the trial of George Floyd, his sickle cell trait became an issue. And I can say that if we didn't all see a knee on his neck, he could have died from sickle cell trait. So something that we should all be cognizant of. Before I end, I show this paper. I show this to say, oh, when someone says, oh, should sickle cell disease be reclassified as a disease state? I don't know, Dr. Ajayi, but I would like to ask, I say, exactly what is a disease anyway? Even the WHO has difficulty defining what a disease is. They say that they define health as state of well-being, not just the absence of disease. I ask you, what is a disease? A disease is context dependent. I've mentioned before how sometime 80 years ago, same gender attraction was a mental illness categorized in the DSM, in the Diagnostic and Statistical Manual. Now it is normal. Years ago, osteoporosis is a disease of women, comes with old age. Today, it's a disease that needs to be treated. If you challenge the average person and say, exactly what is a disease? Give me an example of a disease. A lot of people take the position that, I don't know if you're familiar with Justice Stewart. When asked to define pornography, he says, oh, I don't know how to define it, but I know it when I see it. I know it when I see a disease. I say, well, maybe we need to think about it more carefully. I don't know what a disease is, because notions of health and disease differ depending on whether there is a treatment. And as I've mentioned, what is a disease changes over time. And I don't know if many of you know John Cleese. You know, when we talk about a disease, John Cleese is the British actor in the Fish Called Wanda, who I like the quote that he has, where he says that, look, life itself is a terminal disease. And he adds that life is a terminal disease that is sexually transmitted. So we think of it as a situation, so that when I see patients in our practice who have been sent, especially to me, to discuss the finding of sickle cell trait, I counsel them. Everything I know to tell them is what I learned from Timon and Pumbaa. Hakuna Matata. Just relax. Just relax, right? Because the best medicine for rheumatism is to thank God that it's not gout. People with sickle cell disease will have normal quality of life and normal life expectancy, although you can have a child with sickle cell disease, but you will be normal. And that is the way that I've generally approached my patients. None of these discussions of, oh, you could have renal medullary carcinoma, or you can die playing football. I'll say that the football people need to calibrate training and conditioning to take care of everyone. And I do not agree with routine screening of patients, of individuals with sickle cell trait. Thank you. This is all I have to share. I'm sorry I went over for a few minutes.
Thank you very much, Gladstone. I'm not surprised. So I'll hand over to Dr. Timie to coordinate the question and answer session. Timie, over to you.
Thank you very much, Gladstone. Sorry, I was a bit late in joining. The clinic ran for longer than I expected today because we are doing an exam, but I caught it at the beginning. I want to thank you for this well laid out presentation. At the end of the day, you keep on asking, is sickle cell trait a disease, just like you said, or just a trait? And just crosses my mind that a lot of things you said is taken for granted in Nigeria, where the bulk of the patient or the traits are residing. Thank you very much. I think we have quite a few questions, but we have a lot of comments in the question box, the chat box. President Okolo was asking, flight to Jos, where Kuru is above 4,000 meters, may be problematic for us. That is a comment. I think there was a place where Leto was asking for the title of the movie you referred to earlier. Which of the movie was that?
Oh, it's Remember the Titans. It's Remember the Titans.
Remember the Titans.
Professor Okolo. Yeah, I didn't know about Kuru. I tried to Google, is there any place in Nigeria that is being inhabited that is over 4,000 feet? I didn't know. Yes. So at least about 50% of patients with splenic infection, about 3,000 or below. So if you are flying to Kuru, bear in mind that that's a risk too. Thank you.
Kuru is the highest point of the plateau in Plateau State. And remember, there is still Mambila Plateau. So we have high altitude areas in Nigeria.
Yeah. Well, Dr. Omoshalewa, this is stimulating lecture. What are the things somebody with sickle cell trait should avoid? This is a question. What should we avoid?
I will say though that like to Dr. Onifade, she says the scary stuff. I was actually aiming for the opposite. I was actually aiming to say that sickle cell trait is not someone we should be scared of. A lot of databases have come along that are describing associations, and most of the associations are moderate. For example, if I say that the risk of a blood clot is, I think it's about, the odds ratios are about 1.5 higher than controls. If the underlying condition is rare, 50% more, if I'm 50% more likely to be struck by lightning in the place where I live, I don't really concern myself with that, because very few people are struck by lightning. So that's the idea that I have. I'm trying to say that we should not adopt the American hysteria around sickle cell trait, because of course it will be ruinous for our health system, where there are 40, 50 million people with sickle cell. In terms of what to avoid, my sense is that sickle cell trait, apart from understanding that I have a chance of having a child with sickle cell disease in the future, based on the health status of my partner, the message that the American Society of Hematology and that I support is the idea that the person with sickle cell trait does not need to do anything differently. The people who organize college sports, professional sports, the military, need to calibrate training to take into account the temperature outside, because when the American military took into account the temperature and stuff, it was not just the people with sickle cell trait. The risk of death did not just come down in people with sickle cell trait. The risk of death reduced across the board. So to me, if the only people who die mostly die playing American football, mostly die doing conditioning and practice, situations where the person themselves are not in charge of the intensity of the exercise, to me, that's a message to say that the coaches, the people who push athletes, who push soldiers and people who are exerting sports need to take it easy and create an environment that is suitable and it's conducive to everyone, regardless of whether they have sickle cell trait.
Thank you very much. There are some questions from Dr. Harosolipo, Pajolu, and Airewele concerning hemoglobin C, or those who have F, persistent of hemoglobin F. Do they suffer from similar thing that you have with sickle cell trait, hemoglobin SC, hemoglobin C trait, and those who have maybe hemoglobin S and persistent F hemoglobin? Do they have similar risk as we've described here? I put about 3 or 4 questions together, but it had to do with hemoglobin C and F.
The hemoglobin C data, they have seen data that indicates that those with C trait, C as in cat trait, are more likely to have invasive pneumococcal disease. The risk ratio has shrunk since effective pneumococcal vaccines. I have not seen any indication that those with, I've seen a paper that says that those with C trait may also be more prone to creatinine-based chronic kidney disease, but I've seen other papers that disagree. So I don't think there's any agreement about the risk. So all of these risks have not been corroborated in the C. For those with the F trait, I have not come across any. I've seen publications that describe pathologies in patients who are compound heterozygote sickle and fetal, who are S hemoglobin persistent F, but nothing about the person who is F trait. So an F trait person does not have the same kind of risk.
There's a question here, brilliant lecture, thank you. Thanks. Will you give SCT blood, I think sickle cell trait blood, to patients with sickle cell disease in crisis?
I would say that in general, it depends on what kind of crisis. The general guidance is that giving a blood transfusion to treat pain is not advised, because it typically does not make a difference. But in a crisis, for example, where a person has acute chest syndrome with significant hypoxia, acute chest syndrome with significant hypoxia, yes, a sickle cell trait blood will make a difference. The reason why, as a blanket rule, at least in the West, where sickle cell trait blood is not used in patients with sickle cell disease, is that the blood bank has no way of knowing whether the blood that we're transfusing is being used for a ongoing transfusion program. Because when we're doing blood for ongoing transfusion program, the goal of the transfusion is to suppress native erythropoiesis such that the sickle hemoglobin level is less than 30%. So if you transfuse sickle trait blood, there is no way to do that. But as a practical matter for an acute transfusion, sickle trait blood will be useful, especially in a place like Nigeria. It's just not used in Western countries because we also do not want to confuse those who are getting blood and trying to check the level of sickle hemoglobin that's left.
Trying my practice to avoid it here. When we are transfusing sickle cell disease, we try to avoid as much as possible transfuse sickle cell trait to them, as much as it is possible. But it's not all the time. Right.
And then there's a question, Dr. Fajolu says sickle cell does not affect Caucasians. That is not actually true. The prevalence of sickle trait in Sicily it's over 10%. And this is before the Nigerians started moving to Italy. So the sickle cell trait affects Europeans, especially around the Mediterranean. And this is even before all the migration. So we have patients with sickle cell disease who are Caucasian, several of them.
Yeah. So how about among Arabs too? They themselves,
yes, we a lot of Arab
and Indians.
Many of them who have compound heterozygote sickle cell and thalassemia.
Okay. All right. I think I've gone through as much of the questions that I can find. Most of the things we have are questions that everybody is excited by what we have listened to today. Similar as if somebody should specialize in sickle cell trait as we specialize in sickle cell disease or vice versa. But one thing that is interesting in this is that the other genetic abnormality that exists with this disease, which in our own practice here, we are not probing, now shows us exactly what is happening in sickle cell disease itself and sickle cell trait in some people, where you have some people who have sickle cell trait and present as if they have the disease itself. And those who have sickle cell disease, some of them have very severe disease. You are wondering what is happening. And it's because we are not probing deeply into what is happening in the genetic environment in this patient. As we continue to unveil this disorder, we continue to see a lot of wonders or a lot of things that is existing with sickle cell disorder itself and is making it to look with various presentation and varied manifestation in so many people. Thank you very much, Gladstone. Hope to see you again.
Thank you. And I would like to end with Dr. Kolo's comment that if you see a person who has sickle trait, who has disease, look for coexisting conditions.
Genetic
pyruvate kinase. Yeah, pyruvate kinase is one. Perhaps it's not what you are seeing is not even sickle hemoglobin, because if you do gene sequencing, it turns out not to be. Thank you very much for the attention. It was fun.
Thank you very much, Gladstone. Thank you, Temi, for moderating. And I'd like to thank Shea, the student, for you earlier before the presentation started. So I'd like to hand over to Dr. Mobolaji Lawal to say a few words before we close. Over to you, sir.
Yeah, thank you very much, Dr. Eletu. Nothing much, just to thank the speaker. I predicted that it was going to be a very interesting session. And it has really exceeded my expectation. I particularly enjoyed the session because of the various, the fact that it touched various aspects, so many things working together in this lecture. And I think it's an outstanding piece of lecture from Professor Airewele. So thank you very much, Professor Airewele. I think we will see you again next year or before then.
Yes.
Thank you.
Yes.
Thank you. Thank you. Thank you, Professor Temie, for very ably moderating the session. It's nice to hear from the Nigerian perspective. And, I again thank everyone for coming. I recognize very senior people who have joined us, Professor Ebono, Professor Angela Okodo, Dr. Agbacho, and all the people who joined us from diaspora. We are always honored to have you here with us. So on that note, I want to say that we have had yet another brilliant session, and this group meets every month, the last Thursday of every month. And we usually have interesting topics that are based mainly on clinical matters. And that is why we call it Grand Round. So you are welcome anytime we are on. So thank you all again and have a good evening. Over to Dr. Eletu.
Thank you very much, sir. On behalf of the Guild of Pediatricians in Private Practice, I'd like to thank all of us for joining the session today. Special thanks and appreciation to Gladstone. And like the chairman said earlier, we are very glad to have you, and we've had a fantastic session. He has predicted that we'll be back this year. So don't be surprised when we call on you again. We hope to meet next month, 25th of April. And we have yet another fantastic lecturer who has told me, she's assured me that it's going to be a very stimulating presentation as well. So have a wonderful Easter holiday